today, we are going to discuss one of the important issues, the exercise management in adolescents with type 1 diabetes. The talk is conducted in the absence of any commercial or financial relationship that could affect what I will tell now. The objective of the talk is mainly the role of exercise in adolescents with diabetes, type of exercise, and diabetes management during exercise, especially in diabetic adolescents. As we all know that the cornerstone of diabetes care is diet control, insulin therapy, glycemic control, and the physical activity, the most important topic we shall discuss today. These all factors affect the quality of life in diabetic adolescents. As we all know that diabetes should not prevent children and adolescents from exercise, whether they are occasional fun activity or at a more high performance level. Adolescents may be engaged in more structured exercise as school sports and extracurricular activity, which may involve competition. The exercise management of adolescents with type 1 diabetes is quite complex, and one approach does not fit all. Even when all factors are kept constant, an individual's response to exercise may or may not be predictable on repeated exercise occasion. What are the factors that influence glycemic response to exercise? The type and the intensity of the exercise, the duration of the activity, and lastly, the amount of insulin on board, person's stress and anxiety levels. Here is one of the most famous one, Tony. He was a champion. He has been diabetic and doing sports indefinitely doable, but you just have to be on top of it so you don't hurt yourself. This is what he have said. He has been catch up and he never held back that he has diabetes. He's standing as the top male trumper in the US in the age of group during 2010. To date, he's won 9 national championship titles, including 2 golden medals and 1 bronze at the 2010 in the Junior Olympics. His training schedule is 3 hours twice a week. He plays home gym and another 2 times a week at the gym itself. He doesn't just push himself on the trampoline or mat. He keeps close watching on his blood glucose level. For Tony, that means checking his blood glucose regularly and keeping fast-acting sources of glucose on hand at all time to treat dips. While blood glucose level a little on the high side don't hurt his performance. Tony says he has to watch for lows during practice and playing. He eats a higher carb meal before he go out. If he is a little low, he eats some fruits or drink apple juice. He does his best to prevent lows during events. There are times when he needs a break to tend to his blood glucose despite the extra work to manage his diabetes. He says it's helped me get where he is now. His mom taught him never to use diabetes as an excuse. He always likes to play till he is a champion. What happened during exercise with the glucose? The glucose is the main fuel of source during exercise. Glucose uptake by skeletal muscle can be increased up to 50-fold during bouts of exercise. In normal individual, the glucose provision for exercise originates predominantly from the liver as a result of increased level of glucagon and reduces circulating level of insulin. During exercise in type 1 diabetes, the insulin level cannot be rapidly changed. The counter hormone response can be either blunted at the time or can surge as a consequence of a high intensity exercise or competition. This hormonal imbalance may result in hypo, hyper, or even euglycemic. What are the known types of exercise? Usually we have 2 types, aerobic and anaerobic exercise. The aerobic exercise uses muscle and liver glycogen, blood glucose, and free fatty acids as the main energy source. While in anaerobic exercise is fueled by energy stored in the muscle through glycolysis. Glycolysis occurs in the muscle cells during anaerobic exercise without the use of oxygen. in order to produce energy quickly, thus producing lactic acid, which causes your muscle to fatigue. Usually, what are the main differences between aerobic and anaerobic exercise? These are the in aerobic, there are presence of oxygen, usually moderate intensity with longer duration, develops stamina, burns calories during the activity. While in anaerobic exercise, there is absence of oxygen, high intensity, short duration, develops force, burns calories even when the body is at rest. In aerobic exercise, the heart pumps is strengthened, increased, decrease in the resting heart rate, the blood pressure is low intensity endurance, and increased capillary density. The lung muscle endurance increases and decrease of the body fat. In anaerobic exercises, the muscle strength increases as well, the power increase, blood pressure decreases with high intensity endurance, the muscle size increases, connective tissue also is strengthened, and the body fat is decreased as well. Actually, the exercises may change from aerobic to anaerobic, in which we all know that of the aerobic may be very fast in strength, the weightlifting, powerlifting, golf. In aerobic, there is more racing, walking, inline skating, running. These are types of aerobic exercises. With regular exercise, we have effect on the bone mineral density, the tissue insulin sensitivity, the antioxidant capacity, the glycemic control, even the body composition, muscle fat ratio, and as well the vascular function. What are the recommendations for physical activity? In spite of the health benefit of engaging 30 to 60 minutes of moderate to vigorous physical activity on a regular basis, most youth do not follow this recommendation, even those with type 1 diabetes. We have PA levels and cardiovascular respiratory fitness tends to decrease the age, encouraging PA since childhood may force the maintenance of an active lifestyle into the adulthood. Well, these are the most important factors affecting the exercise and the blood glucose response. The exercise, the type, the duration, the regime changes starting from the blood glucose level, circulating insulin level, hypoglycemia associated autonomic failure, the body concern and the mental stress during the exercise, and the environment, as that the heat, cold, or the humidity of the environment. We have actually 4 types of training of physical activity: continuous moderate, continuous vigorous, intermediate moderate to vigorous, and lastly the resistance training. Well, in normal adolescent, the drop in blood glucose that follows the onset of physical activity inhibits pancreatic insulin secretion, increase hepatic glucose production, and thus balancing glucose uptake and output. However, continuous moderate physical activity is effective in reducing the blood glucose in patients with type 1, as it increases the skeletal muscle glucose. In individuals with type 1 diabetes, the physiologic mechanism of glucose counter-regulation are altered. As in patients with type 1 diabetes, the endogenous insulin production is absent, the body is unable to control its availability, increasing the risk of hypoglycemia. Compliance with carbohydrate replacement and insulin doses reduction are commonly recommended. Here are the most important types or examples of continuous moderate activity as water aerobics, bicycling, tennis in double, and general gardening. The other type of continuous vigorous activity is the continuous vigorous physical activity. In high intensity exercise, hypoglycemic episodes are less common than light to moderate. On the other hand, there is an increase in release of catecholamines. This results in post-exercise hypoglycemia, hyperglycemia rather than hypoglycemia. Extra carbohydrate replacement or insulin dose reduction may exacerbate the post-high intensity exercise hyperglycemia. This is quite important difference between the 2 types of physical activity. Here are the most important types: racing, swimming. Tennis in single is quite a vigorous physical activity. Heavy gardening or hiking up hills, this is considered as well a vigorous physical activity. It's the best thing is to do both intermittent, moderate to vigorous physical activity. This is quite very beneficial for adolescents with type 1 diabetes, as it relieves the blood glucose during and after the activity, with reduction the rate of hypoglycemic events without exacerbation of the hyperglycemia. This is quite important to have this mix of moderate to vigorous physical activity. In this condition, there is the rise of lactic level, which may contribute to less reduction in the blood glucose, which is needed for the exercise. This is done by antagonizing the action of insulin, stimulating glucose production by hepatic gluconeogenesis. The catecholamine spike that occur in response of intermittent vigorous exercise stimulate hepatic glucose production and simultaneously inhibit insulin-mediated glucose uptake. Just here is the types of intermittent moderate. It could be very well in football and volleyball. The last thing is the resistant training. It is recommended to engage diabetes with the resistant training 2 to 3 times a week. This will result in maintaining or increasing muscle strength, increasing energy expenditure, reduction in visceral fat, and improving bone density. Well known, it is important for cardiorespiratory fitness, muscle strength, improve the lipid profile and the glycemic control of these children. Right? Most physical activity is quite a combination of both. The activity is typically classified according to which energy system is predominant. Well, here the aerobic is mainly for cardiovascular, while that of the anaerobic is mainly for muscle fitness and strength. Okay? Is the omission of insulin dangerous? Actually, don't omit insulin during exercise. Metabolic control is obviously poor during the time that insulin is omitted, and there is always the serious risk of ketoacidosis. This is a difficult problem because the practice obviously works, and the athletes with type 1 diabetes are often willing to take the risk. When insulin is not available to assist the transport of glucose into the skeletal muscle, glucose uptake is decreased, glucose release from the liver is increased, and there is the rise of the blood glucose. Without adequate insulin, skeletal muscle will be forced to rely on fat as a fuel, and this may result to ketones body. Be careful. Athletes with diabetes should not exercise when the blood glucose is more than 250 milligram per dl with ketosis, or even 300 milligram per dl without evidence of ketosis. We have to have some sort of euglycemic condition to let them exercise. Other questions needed to be answered include: does hyperglycemia interfere with athlete performance? Does improved glucose control translate into improved performance? And what is the target of the glucose? Insulin should be decreased by 20 to 50%. Reduction of both short or rapid acting and intermediate long should be done. The athletes on pump should decrease the bolus dose by 20 to 50 and discontinue the basal during exercise and decrease the basal insulin to 25 after exercise is completed. The site and timing of insulin injection can affect the glucose response. If subcutaneous insulin is injected over the muscle that will be actively contracting, insulin absorption will be accelerated. Insulin may be also absorbed at a faster rate if the exercise begins less than 30 minutes after the injection, and if recommended to insulin should be injected after 60 minutes before the start of activity. Changing the regime of injection site, thigh versus abdomen, is generally not recommended. Usually fixed to where you give the insulin. The general recommendation is to rotate the injection site within the same region rather than to alter the region that is used. The diet involves a specific amount of carbohydrate and appropriate time to match the anticipated reduction in the blood glucose. This is very, very important. And all athletes with diabetes know this as by heart. They drink drinks containing 5 to 10% of carbohydrates, or using commercial sports with 6 to 7% of carbohydrates is sometimes recommended. However, drinks containing more than 10% carbohydrate causes gastrointestinal distress and should be probably diluted. What is our recommendation of children with PA of type 1? Between 6 and 9, competitive activities with flexible rule are introduced, as gym, skating, swimming, cycling. This is good for them. At the age of 10 to 12, football, swimming, tennis, volleyball, artistic gymnastics, dancing, all are nice competition to do with this age group. In some sports, auto racing, parachuting, and rock and mountain climbing and diving are quite dangerous. They should be discouraged. What is our conclusion? The choice of the PR for diabetics should be depend on individual abilities, goals of exercise, and most probably enjoyment. The chosen activity or sport should also be age appropriate. We should choose the appropriate sports for our children and adolescents. Sports in early childhood should thus have as the main objective playing, taking short walks, running, jumping, swimming, and turning cartwheel as well. The most common acute risk of competitive athletes is exercise-induced hypoglycemia and deterioration of hyperglycemia and ketosis brought by the physical activity. Blood glucose is relatively unchanged during exercise in individuals without diabetes because glucose uptake by skeletal muscle is precisely matched by the glucose released from the liver. One important control over this mobilization of fuel is the reduction in the circulating insulin, which is given by injection. And lastly, thank you for your attendance and